If you've ever worked in the skilled trades, or used a power tool for that matter, you know how important proper safety precautions are. Unfortunately, even when precautions are taken, mistakes can and do happen.
I'm gonna smooth out the big patch with the belt sander. After that, we'll
Yeah. Woo! Somebody's gonna get hurt real bad. If you're lucky, you may end up with little more than a surprise smile, but sometimes the result is more permanent. Now, before we take a look at our first patient, I need to give a big shout out to Cam and his YouTube channel, Blacktail Studio, as well as our slow motion cameraman, Chris VTV, who collaborated with him on the video, Woodworking Injuries in Slow Motion, which will be the source material today as we take an in-depth look at hand and forearm anatomy with a surprise or two along the way. Please note, this is an educational video, and as such, all depictions of trauma are demonstrated on ballistics gel and carefully contextualized within a lesson on human anatomy in accordance with YouTube's community guidelines. Without further ado, I'd like to invite Professor Blacktail to introduce our first power tool and patient.
First tool we're going to look at is the jointer, and responsible for approximately 10,900 injuries every year and terrified me for a long time.
With the interphalangeal joint of the thumb pressing against the wooden plank, the meat of the distal phalanx is positioned ominously above the cutting head of the jointer. Unfortunately, this tool has a lip that can grab and pull on the tip of the finger.
This entire process took just a millisecond and the entire thumb was gone, but it shows you it doesn't just cut it off cleanly, it really chews it up,
grinding it to a pulp. Coincidentally, pulp is the term used to refer to the fleshy mass on the palmar aspect of the extremity of the finger.
It says with pulp.
This dense fibrous tissue lies under the epidermis of the entire fingertip, supporting the distal phalanx, but not against the jointer, which ultimately
folds it back on itself, pinches it against that jointer bed, and eventually sheared the whole thing, even some bone coming off there. It was pretty gruesome.
Due to the damage suffered by the severed digit, this patient is looking at suboptimal conditions for a replantation procedure, or the surgical reattachment of a body part that has been completely cut from the body.
Not this much. I like the one that says some pulp.
A 2018 case report written by Shata M. Suleiman et al. And published in Plastic and Reconstructive Surgery Global Open explains that while the overall success rate of limb replantation surgery is around 83.2%, the mechanism of injury plays a role in the outcome. Guillotine amputations, for example, carry a better prognosis than do crush amputations. Intuitively, this makes a lot of sense. A cleaner cut means less damaged tissue, leaving the surgeons more to work with.
That makes me uncomfortable.
Yeah, that was like your whole thumb.
A large portion of the distal phalanx is still intact, and since the associated bone looks to have been severed cleanly at the joint, there is a chance of success. Of course, this will include reattachment of both the extensor pollicis longus and abductor pollicis longus tendons, which anchor to the distal phalanx. But you may be surprised to learn that there is no muscle in the damaged portion of the thumb. In fact, the 30 muscles of the hand are all located in the palm, while many movements of the hand are mostly started by muscles in the forearm. And with a little slip of judgment, all that biological complexity goes right out the proverbial window. Just your friendly neighborhood ortho reminding you to be safe out there. But don't take my word for it.
When you walk up to any tool, you need to think, is this cut safe? Is there a safer way to do this? And am I mentally here? Am I stressed or tired?
The man in that clip, Jonathan Katz-Moses, himself an expert woodworker and YouTuber, actually suffered an injury quite like this. And like he says, if the answer to any of his questions is a no, you'd better find another way, or come back later.
The next tool we're going to look at is the router, or the CNC. It is essentially a motor that spins a carbide bit anywhere from 10 to 20,000 RPMs.
Thanks, Professor. And what do you propose we do with that information? But of course, A quick swipe of the distal phalanges, this time of the pointer and middle fingers. Well, fellas, can we slow it down a bit?
It's very clean,
Yeah.
but still not that destructive.
Music to my ears. And yes, every finger has a distal phalanx. Distal meaning situated away from the center of the body or from the point of attachment, while phalanx refers to one of the digital bones of the hand or even of the foot.
No bone damage, but probably wouldn't feel very good.
Thankfully, an article written by Dr. Paris Jafari et al. For International Journal of Molecular Biology reassures us. Fingertip response to trauma represents a fascinating example of tissue regeneration. Regeneration derives from proliferative mesenchymal cells, blastema, that subsequently differentiate into soft and skeletal tissues. Mesenchymal cells are multipotent stem cells found in bone marrow, loosely organized embryonic connective tissue of undifferentiated cells that give rise to most tissues such as skin, blood, or bone. These are cells that have an ability to turn into a number of different tissues.
I thought it doesn't pull it in like the jointer, just nipped off however much I let it put it, or however much I put into it.
But hey, if you find yourself alone with a CNC machine, don't get any ideas.
Unquestionably the most terrifying tool to me personally, it is the chainsaw, and it causes approximately 36,000 injuries every year.
Many of those injuries occurring to the lower leg due to the manner in which the chainsaw is typically operated. That is to say, cutting wood in a downwards motion, often close to the ground. To accommodate this patient, we'll need to brush up on some anatomy below the belt. Get your head out of the gutter. The lateral aspect of the lower leg is the home to the fibularis, or peroneus longus, and brevis muscles, which work in tandem to evert, or turn outwards, the foot, and plantar flex the ankle, or point the toes downwards. In this instance, while the laceration is relatively shallow, an approximate depth of maybe a centimeter or two, the peroneus longus, which lives over top of the peroneus brevis, is in greater danger. The fibularis longus extends down the lateral compartment of the lower limb, where at the midpoint it tapers into a long tendon that descends into the foot in order to achieve the aforementioned functions.
In a way, most saws are removing some material, but none remove material like a chainsaw. It is literally hogging out flesh and bone.
And I fear that in this case, it is hogging out a small sliver of the fibularis longus tendon, right around the area where the muscle tapers into connective tissue. Put your fingers down the lateral aspect of your lower leg, where Professor B administered the cut, and point your toes. You'll feel this structure moving. If the patient was lucky, only the muscle tissue above the tendon would have suffered a laceration. You see, muscle generally has a far greater healing potential than connective tissues like tendon and ligaments due to higher blood flow, and thereby nutrient and oxygen supply, which feed the tissue during the healing process. Generally speaking, skeletal muscles require an abundant supply of blood as their primary function, contraction, consumes large amounts of oxygen to replenish ATP that is hydrolyzed during the process. Conversely, connective tissue, rather than directly supplied by blood vessels, is perfused or bathed in blood only when movement occurs in the associated region. Therefore, they have limited opportunities to heal, as the constituents necessary for the healing process are usually in shorter supply. Depending on the severity, a lacerated muscle may require sutures. Otherwise, rest, compression, and immobilization, followed by a proper rehabilitation protocol, will usually do the trick. The recovery process for a severed tendon necessitates surgical fixation and far more patience on behalf of the patient.
Help! I'm supposed to have surgery, but my doctor disappeared.
Okay, Josh, this is the shot you've been waiting for.
In an article for the Journal of Knee Surgery, Sports Traumatology, and Arthroscopy, Dr. Pim Van Dyke et al. Explain, the median duration of the total immobilization period after primary fibularis longus tendon repair was 6 weeks, 7 weeks after tenodesis or reattachment to the bone, 6.3 weeks after grafting, and 8 after end-to-end suturing, with range of motion exercises beginning within 4 weeks post-op. At the level of the injury shown, we also need to consider the nearby nerves, such as the superficial peroneal nerve that lies just in front of the peroneal tendon. If injured, it would cause numbness on the top of the foot and weakness in everting the foot at the level of the ankle.
Also, I don't really know how to use a chainsaw. I've never been trained, and there are parts of Europe that require people to go through special training just to use one or a license.
Thankfully, in this case, we're simulating workplace trauma. So, Professor B's lack of training might actually enhance the process of cutting crudely into a ballistics gel leg.
Even though I am dangerously underqualified and really don't know how to use it, I will have a Ruby Ridge standoff if anybody comes for my chainsaw.
Never try to take a chainsaw from Professor Blacktail. Obviously, this second laceration is much deeper, cutting diagonally towards the lateral aspect of the left leg, above the knee and towards the back. Can you take us in for a closer look, Professor? At a depth of approximately 1.5 inches, it did not appear that the blade cut all the way down to the bone. But you don't need to touch bone to create a whole world of problems. First, the iliotibial tract, or IT band, is in trouble. It's almost as if Professor B was aiming for it. This long tendon runs down the outside of your leg, connecting from the top of your pelvic bone to just below your knee. Its job is to stabilize the hip and knee, though it also supports movements of the hip and knee through the action of the gluteus maximus and the tensor fascia lata muscles. This tendon is large and quite robust, and acute lacerations are quite uncommon. But that really means nothing to a hungry chainsaw 1.5 inches into the side of our patient's leg. This type of injury would require operative repair, encompassing initially irrigation and debridement to thoroughly clean the wound and affected area, suture repair of the tendon tissue, fascia, and muscle if possible, cauterization of any superficial blood vessels, and watertight closure of the various tissue layers and skin, all followed by an extensive rehabilitation protocol. In all likelihood, the biceps femoris and vastus lataris have also sustained damage here. Since the chainsaw was higher near the front of the leg, the muscle belly of the vastus lateralis likely sustained a partial laceration. Since we've already established that muscles generally have a better recovery prognosis than tendons, it is the myotendinous junction of the biceps femoris for which I am most concerned. The myotendinous junction, or MTJ, is the interface between the muscle and tendon, and where force is transmitted between the two tissues. As mentioned before, the region of the MTJ has a somewhat better blood flow than does the tendon itself. But this slight difference won't save our patient from a challenging rehab adventure. Odds are both the biceps femoris tendon and the iliotibial band have been severed completely, and rehabbing both of these at the same time would really suck. The biceps femoris facilitates movement at both the hip joint and the knee joint. And if it's been severed at either junction, movement at the other end will be compromised. At the hip, the long head of the biceps femoris allows for thigh extension and external rotation, while at the knee, the biceps femoris facilitates knee flexion and external rotation of the lower leg, which basically means,
"Give it to me straight, doctor, I can take it!"
Our patient will not be walking. As stated in NIH, rupture of the biceps femoris tendon can be treated conservatively or surgically, depending on the severity of the tendon retraction. Right. Since normally they are under tension, when a tendon is severed and that tension is no longer there, they tend to retract like elastics, only inside the body, often sequestering themselves in muscle tissue some distance away from the actual injury site. Fortunately, the aforementioned article goes on to say most of the patients recover well and are able to return to high-level sports activities if they receive a timely diagnosis and appropriate treatment. Timely diagnosis and appropriate treatment. Recurrence is highly common. The article uses the word rupture, meaning break or burst suddenly, because severed biceps femoris tendon due to laceration is also an uncommon occurrence. Bleeding would be profuse, since the muscle is rather large, but since the cut is largely on the outside of the leg and the major blood vessels in our legs, such as the femoral artery, are located towards the inside, he may have dodged the exsanguination bullet. Unless, of course, the chainsaw severed the popliteal artery when wrapping around towards the back of the leg. Of course, Had it done so, the tibial nerve would also be severed as it descends through the thigh into the lower leg alongside the popliteal artery. For our patient's sake, I hope our trusty chainsaw wasn't in the mood for major vessels and nerves.
Some of you already know that my job prior to being a woodworking YouTuber was a life flight pilot. I used to fly the ambulance helicopters.
Well, interns, it turns out Professor B also has experience in the medical field, and with the type of injury suffered by our next patient.
One of the very first flights I ever took was to pick up a guy who had fallen onto a running table saw, landing on his forearm when his dog had jumped up onto him.
Oh, that is rather unfortunate. And I think of all the injuries we've seen today, this is the one that I would least like to experience.
You can see here just how terrifying that must have been for that guy.
A large piece of flesh is hanging from the arm, and while a quick look at an anatomy textbook will reveal the largest and most superficial muscle in the corresponding part of the forearm is the brachioradialis, there is a lot more that the attending physicians will have to contend with. The forearm is extremely complex, as it houses many of the muscles and connective tissues that facilitate fine motor movements in the hand. As we move from supination, palm up, to pronation, palm down, the aptly named radius bone rotates around the ulna, shifting slightly the tissues that are attached to it. The aforementioned brachioradialis muscle is one of those tissues. It originates on the lateral supracondylar ridge of the humerus and connects into the styloid process of the radius, so that when the arm is supinated, it's on the lateral side of the arm. When we enter into pronation, this muscle is pulled towards the medial edge of our arm, right into the teeth of the unforgiving table saw. The worst part is, we're just getting started. I'd like to introduce you all to the flexor pronator muscles of the forearm. These muscles reside on the volar, meaning related to the palm of the hand aspect of the forearm, and are responsible for, as their name suggests, pronating the hand and flexing at the wrist and into the fingers. Without them, you cannot grasp or grab things. Each of these muscles transition through a myotendinous junction into a tendon that helps to facilitate the aforementioned actions. For each of the 5 muscles in this group and their associated ligaments, we'll talk about where the laceration would have occurred: muscle belly, myotendinous junction, or tendon. Before we do so, it should be noted that these flexor pronator muscles act in antithesis to the extensor supinator muscle group to facilitate the normal movement of the hand, kind of like yin and yang. But we'll leave that for another day.
Thank you!
Interns, if you're wearing a shirt with sleeves, now's the time to roll them up.
You're gonna take it down, boom. You're gonna pop it right like that. You're gonna take your thumb, hand under there, and you're gonna tuck. You're gonna tuck, you're gonna tuck, you're gonna...
First, the pronator teres tasked with pronating and flexing the forearm would be severed through the muscle belly. The flexor carpi radialis, which provides flexion of the wrist and assists in abduction of the hand and wrist, would be severed through the muscle belly also. Palmaris longus, which not all of us have, and whose role is to help with wrist flexion, may be severed through the tendon as the transition point occurs slightly earlier than the other flexor muscles. Now, if we look at the attachment point of the flexi carpi ulnaris and the flexor digitorum superficialis, they almost look like they could be out of harm's way. And again, that might be so, if not for the rotation of the radius. What the attending surgeon would be looking at here would be a jumbled mass of retracted muscle and tendon. It would be very challenging to identify and repair each of the individual structures all at once. And this would be complicated by the fact that the radial artery would also have been severed in the incident. This is the artery that is targeted when a person decides that life is not worth living. So severe hemorrhage and the associated hemorrhagic shock is a serious concern. This is a form of hypovolemic shock in which severe blood loss leads to inadequate oxygen delivery at the cellular level, which can result in death. And the list goes on. There is a possibility that the median nerve, which provides motor movement functions to the forearm, wrist, and hand, was severed. If this occurred, anything beyond the point of the injury will suffer total loss of function. Luckily, some nerve injuries can be surgically repaired. but there is no guarantee that the patient will ever regain full function or feeling. Jimmy DiResta, a fellow woodworking YouTuber featured in Blacktail's video, shared his first-hand experience with this type of injury and outcome.
The wood shot into my forearm that was on the adjustment knob, and I leaned forward and I threw my hand right on top of the blade, pulled it in and like pulled it down like that, and I knew something had happened.
Not exactly what happened in our simulation, but horrifying, no less.
My attention was all on this blasted forearm, and when I looked over, I saw my pinky lying in my palm.
A small branch of the ulnar nerve that branches into the little finger would have been surgically reattached or repaired during the replantation procedure. And yet...
Functionality now?
I spent a few days in the hospital, they sewed it back together. It doesn't really work past the cut.
After catastrophic injury to a nerve, we will help the patient to maximize function. But again, this is not always possible. They will need to relearn to contract the muscles associated with the damaged motor pathway, and in many cases, learn to use other muscles to compensate for any lasting deficiency. Oh, and one more thing. In regards to the actual radius bone, it doesn't look like there is much of a bone fragment or fracture to repair. Rather, a thin line of the osseous tissue has been shaved away and chewed up by the saw. In a case such as this, where there was not any real fracture, but more of an injury only to the periosteum, or covering of the bone, and perhaps a thin sliver of the cortical covering of the bone, and irrigation and debridement of the wound and bone, followed by closure of the wound, would be sufficient. When all is said and done, this patient is looking at one hell of a road to recovery. After the wound and underlying tissue have sufficiently healed, our patient will start his rehab program. This will include a program of flexibility and stretching to lengthen shortened, contracted muscles, and to mobilize and lengthen scar tissue and adhesions that occur while the tissues have healed. Once he begins to show progression with respect to wrist and forearm movement, he will start strength training to restore functional strength to the hand, fingers, and forearm. Rehabilitation will conclude with more functional training that simulates everyday tasks and progressively improves proprioception and position sense of the upper extremity. And you best believe that this is not happening in only a few sessions of physio. This is going to take a freaking long time. Okay, I think that's enough for today's lesson. Big shout out to Cam and Blacktail Studio for assisting us in our pursuit of anatomical knowledge. There are several injuries in this video that we didn't get to cover today, including another run-in with the table saw that will force us to extend our studies into intricate anatomy of the hand. So let me know if you'd like to see part 2 down in the comments section below. Remember to join me at my online gym, Human 2.0 Fitness, for free, right here on YouTube, where we help you move better and prevent injury. If you liked the video, be sure to give it a thumbs up and subscribe to the channel. If you didn't, be sure to let me know why in the comment section down below. Otherwise, as always, that's been a word from Dr. Chris, not your everyday ortho, where we see one, do one, teach one. Whoa! Whew.